Hello and welcome back to this pathology session. Today we tackle what is arguably the most prevalent nutrition deficiency worldwide and certainly one of the most common anemias you will encounter. IDA. Drawing from the clinical principles, will explore why those iron stores matter, how body signals depletion, and the critical clinical implications, moving beyond the simple definition to the nuances expected for some bizarre exam. To understand iron's role and the cascade of events in IDA, let's use a layered analogy. Imagine our body as a bustling metropolis powered by a sophisticated energy grid. Iron is the specialized high grade scrap metal that is absolutely essential to build and maintain the power generators and keep the city running. So, by power generators, I meant hemoglobin and other iron containing enzymes. The city has a central scrap metal dealer, our intestinal enterocytes, who manages the intake of this crucial raw material. It also has a main power company, the erythroin, specifically erythroid precursors in the bone marrow, that demands huge quantities of this scrap metal to build new power generators, that is our RBCs. Okay, so firstly, let's quickly recap why the scrap metal is so vital. Hemoglobin. This is iron's most famous role. It's the oxygen carrying power generator in RBCs. Without enough iron, you cannot build functional generators, leading to the core problem of anemia. And myoglobin. Iron also builds smaller generators in the muscle for local oxygen storage. Cytochromes and enzymes. Crucially, iron is the part of essential transport chain, electron transport chain, components and numerous enzymes involved in cellular respiration and DNA synthesis. This explains the systemic symptoms beyond just iron transport. IDA doesn't just happen overnight, it's a progressive depletion like the city's scrap metal reserves gradually dwindling, moving through distinct stages. Iron depletion. Pre-latent iron deficiency. The warehouse is emptying. The scrap metal dealer's main warehouse, that is iron stores, primarily ferritin and hemosiderin, is starting to run low. There is still enough scrap metal flowing to the power company for now, but reserves are shrinking. Serum ferritin is the key marker here. It's an acute phase reactant, so a single low reading is very specific for iron depletion. So if ferritin is less than 30 nanogram per ml or more robustly 15 nanogram per ml is indicative. Other parameters like hemoglobin, MCV remain normal, whereas they remain normal. Okay, so in this phase they remain normal. Latent iron deficiency, it's the iron deficient erythropoiesis. Reduced scrap metal flow. So the main warehouse is critically low and the scrap metal dealer is now struggling to supply the power company. The power company's inventory available scrap metal, that is transferrin saturation, is dropping, and the internal transport vehicles, that is transferrin, are eager to pick up any available metal. So serum ferritin is definitely low. Now transferrin saturation begins to fall, less than 16%. The power company, that is the bone marrow, attempts to compensate by upregulating its receptors for scrap metal, that is soluble transferrin receptor, which increases. And hemoglobin and MCV might still be normal, but the quality of new power generators might subtly decline. This is where subtle fatigue and impaired cognitive function may begin before overt anemia. So IDA, the blackout. The main warehouse is empty. The flow of scrap metal to the power company has vitally ceased. The power company cannot build enough new functional generators. The existing ones are dying off and the new ones being built are small and inefficient. The city, the body, begins to experience power blackouts and slowdowns. Low hemoglobin is the hallmark of anemia. Microcytosis and hypochromia. The power generators are small and pale due to insufficient iron for hemoglobin synthesis, that is heme synthesis. Anisocytosis. The new generators are of varying sizes and shapes. Low serum iron, high TIBC. Little available scrap metal, but many empty transport vehicles, transparent, are eager to pick it up. Low transference saturation. Very few transport vehicles are carrying scrap metal. Low ferritin, primary indicator of depleted iron storage. Elevated STFR, the power company is screaming for scrap metal. Okay, the clinical features beyond the blackout. The symptoms of IDA intend beyond the generic effects of anemia, reflecting the systemic importance of iron in our energy grid. So, general symptoms like fatigue, pallor, dysphonia on exertion, direct results of insufficient oxygen delivery. And specific iron deficiency systems are pica, ankylostomatitis, painless, and glossitis, both are painless. And koilonychia, spoon-shaped nails. Restless leg syndrome can be exacerbated or caused by IDA. Impaired cognition and immune function is also observed. And so the critical step is to always ask, why is this patient iron deficient? This is the root cause investigation, finding where the scrap metal is being lost or not taken in. So blood loss. This is the most common cause in adults. That's the leaky pipe. So GI loss, the most critical source, peptic ulcers, especially NSAID induced diverticular disease, hemorrhoids, critically the colorectal malignancy, so and so. And genitourinary loss, menorrhagia in premenopausal women is the common loss. Other causes include hematuria and hookworm infestation, and helicobacter, gastritis, that's it. And increased requirements during pregnancy and lactation and growth spurts. It's the booming city. And decreased absorption, the faulty scrap metal dealer. Celiac disease, gastric surgery, H. pylori infection, etc. And nutritional deficiency, so no scrap metal delivery. Less common as a sole cause, but relevant in vegetarians and vegans. So, as I said, celiac disease, it's like the damaged intestinal lining impairs the absorption. Gastric surgery, removal of acid producing stomach cells or bypassing the duodenum, is the primary site of iron absorption. H. pylori infection can impair absorption too. And achlorhydria or hypochlorhydria, so reduced stomach acid due to proton pump inhibitors, or autoimmune gastritis. It reduces the conversion of ferric to ferrous form, which is the absorbable form. And management. So the management is twofold. Iron replacement. It's done by oral iron. Its first line, ferrous salts like ferrous sulfate, ferrous gluconate, ferrous fumarate are most common. And side effects could be there like dark stools, constipation, GI upset. And to optimize absorption, it's taken on empty stomach. Dairy, tea, coffee, everything is avoided before consumption. And vitamin C can be considered to increase the absorption. IV iron, it's reserved for severe deficiency, malabsorption, intolerance to oral iron, or ongoing significant blood loss. Newer formulations like ferric carboxymaltose allow larger and safer single doses. And treating underlying cause is the second step. This is paramount. Replenishing iron without fixing the leak is like constantly refilling a bucket with a hole in it. This requires thorough investigation based on the patient's risk factors. So that's it on IDA. So I think I've covered everything. And there is this thing called as hepcidin. Let me go through the the important points. When iron deficiency is developing, reticuloendothelial stores like ferritin and hemosiderin is completely depleted before the anemia occurs. So as I have told, the symptoms I have mentioned earlier and causes I have mentioned earlier. So labs, Helicobacter serum gastrin levels are to be checked. MCV, MCH are decreased, iron is decreased, ferritin is decreased, TIBC is increased, bone marrow stores are absent, erythroblast iron is absent, hemoglobin electrophoresis is normal, and if ID is associated with severe folate or vitamin B12 deficiency, dimorphic film occurs, and this dimorphic film is also seen in patients with recent iron therapy. So, suspicion is based on hypochromic microcytic anemia. Diagnosis, we do it based on low serum iron and ferritin, increased TIBC. Investigation, females, menorrhagia, repeated pregnancy, and males, GI blood loss and other non-uterine causes. Treatment, twofold, so oral iron and then treating the cause. So that is it. And hepcidin, I'll mention about hepcidin. So in case of hepcidin, raised hepcidin levels affect the absorption of iron, and there is this thing called as erythroferon. It's secreted from the erythroblasts. It reduces the hepcidin levels, therefore it increases the iron absorption and decreases the probability of iron deficiency. So decreased ferritin and increased TFR1 is seen in iron deficiency. So iron absorption is favored by ferrous form of iron. Acids reduce serum hepcidin, ineffective erythropoiesis, pregnancy, and hereditary hemochromatosis. So that's it for iron deficiency, anemia.